Jazakallah. So for today's session, we have 3 talks. Before we start the session, I would like to invite the chair of today's session. Our first chair is Professor Dr. Najmul Islam. He is past president, Pakistan Endocrine Society and ex-head of department at Aga Khan University Hospital section of endocrinology. Please welcome Dr. Najmul Islam. Our next chair is Professor Dr. Ejaz Vora. He is on his way and he'll join us soon. Okay. So once he is here, inshallah, he will be on the podium. So our first talk for today's session is by Dr. Professor Saeed Meher. He is Professor of Endocrinology at National Institute of Cardiovascular Disease. He is past President, Pakistan Endocrine Society, and he will be discussing about holistic approach in diabetes for primary care physician. Please welcome Professor Dr. Saeed Meher.
हेलो प्रेजेंटेशन चला रहा Bismillahirrahmanirrahim. I'm really honored and grateful to the colleagues in PIMA that they have invited me for today's talk. So I will start with the first talk, and this is something which may not be for something specific about the drugs, but rather a holistic approach about the diabetes, that how we are looking at it and how we see the things in diabetes, that how we are doing it. So in Pakistan, we majority of looking at the things in a way that we are a nation of 245 million people. This is one of the 5th largest population in the world, and we have got 33 million people suffering from the diabetes, which is again the 3rd largest population and one of the highest prevalence of diabetes in the world. Then we have got 40% of the population below the poverty line. So if we look at the things, these things are actually giving us an alarm that the speed with which the diabetes is rising, that's something which is really alarming for this part of the world. What is the cause? The cause is one of the reasons that this pandemic of obesity is going. If you look at 1992, look at the TV and look at the guy, and in 2021 and 2024, look at the television and look at the guy. So this is something which really has transformed the prevalence of not only the obesity, but many other diseases also. Reason? The reason is actually that we have really increased our portion size from a small packet of fries, a small drink, to the prevalence of diabetes. Now, what happens that if you increases your weight, what happens, the most deranged thing when increasing your weight is actually the obesity. So once you are obese, that means you are increasing your chance of heart diseases more than a general population. As obesity increases, you can see from this chart, the prevalence or the ratio of heart diseases will increase. You just increase your 1 kilogram of body weight, and that increases the cardiovascular risk by 3.1%, and your risk of diabetes by 4.5 to 9%. So just increasing 1 kilogram of weight will put you in the problems of the cardiovascular risk and the diabetes. The people with diabetes are 3 times more likely to die of the heart disease. The most common problem or the most common cause of the death in a diabetic patient is usually the cardiovascular disease, and the problem is another thing which actually give the problem is actually the stroke. So people with diabetes are more likely to develop the heart disease. We all know. I'm working at the NICVD, and what I'm seeing, young patients 30 or below 30 years of age, they are coming with the MI, with the heart failures and with the other things. And again, this is something which is mainly related to the diabetes. when you will go from this world. So we cannot change that day or that time, but at least what we can do as doctors, that if you look at the green level, this is the healthy lifespan. So if you treat somebody properly, you can increase that healthy lifespan and you can prevent him from the complications. You can prevent him from some, for example, the cardiovascular complications, the rheumatological complications. So actually what we are seeing, that the period of life free from major chronic disease and disability, so we can increase that, but we cannot increase the age of the patient. Now, if we look at the holistic approach, so it's not only the glucose control, but the main, again, second thing is actually the risk reduction in the management of the diabetes. Another thing is actually, which is nowadays is very important, is the weight management. And last but not the least is actually decreases the disease burden. If you look at it, when the glucose uptake is increased, that increases the glycogenolysis, normalizes the blood glucose levels. But again, if the blood glucose is increased, then definitely the other pathway will come into the action, and there is a balance, is a natural balance in the body that actually maintains the blood glucose in the in our levels. Now, why glucose control matters? What is the reason for glucose control? Now this is again something on your left side is a famous UK PDS study that says that 1% reduction of HbA1c will prevent you from so many complications. But again on your left side, if you look at this one, the reduced total diabetes related cost. If you have got a controlled diabetes, definitely your visits to your doctor will be decreased, your investigations, the cost of investigation will be decreased, and that all will give you 20% decrease in the diabetes related treatment cost. So again, a good control will give you not only the free from complications, but rather a decrease in your pocket. This is something which is new, 2024. I don't want to go into the detail, it's a busy slide. But again, the first thing is actually is the diet and exercise. Then is again something which is metformin. But nowadays, what we are focusing on that right from the start, we should consider the atherosclerotic cardiovascular disease. We try to give them treatment that will prevent the atherosclerotic cardiovascular disease. Then heart failure, which is again something very common with the atherosclerotic cardiovascular disease. Number 2. Number 3, the kidney disease, which is again one of the main reasons for the dialysis in these patients. So we try to treat the patient in a way that we can prevent these complications in these patients. If we move further, then we start the treatment. But what happens that we will not intensify the treatment. So what's happening that when we start the treatment, then definitely after 3 months, this is always mandatory, you look at the patients, look at again the blood glucose levels and see whether your patient has really improved. Is he on a target which you set for the patient or he is not? So this is something which we call as actually inertia, in which we do not intensify the treatment. This is something which is actually the different factors which are related to the patient inertia. So if you look at it, in people with type 2 diabetes, HbA1c more than 7%, taking one OAD, the median time to intensification for a second OAD was 2.9 years. 3 साल लग गए जब हमने उनको सेकंड दवाई ऐड की, और 7 साल से ज़्यादा लग गए जब हमने उनको पहला इंजेक्टेबल ऐड किया. So this is something which may be sometimes on our side and which may be sometime on patient side. So there are different factors from patient's perspective. The insulin or the injectables, the patient feels is a last resort, and we should counsel them this is not the last resort. Then again, weight gain with the insulin, hypoglycemia, but again what I said, that now there are new drugs which may not cause the weight gain. For example, the GLP-1s, they do not cause hypoglycemia. So we have got different options now, rather multiple options for the treatment of the patients. From physician's point of view, we are very busy. We have got a busy clinics. We may not have got enough time or extra time to counsel the patient for something extra. Then these all factors will join together and give it rise that the patient's control may delayed for some time. Again, the healthcare system, what we are looking at it, we do not have got the enough specialist people, enough hospitals which them treat properly, because we are a poor country and everybody cannot afford the private health, or the drugs are expensive. So that's something important where the role of the healthcare system comes into, and that's the responsibility of the government, that they should provide an adequate healthcare or the management to these patients. So what we always need a multifactorial approach. Few things which you always keep in mind, that HbA1c, should we keep it less than 7%, we encourage them to have a physical activity more than 150 minutes per week. Blood pressure less than 140/90, TG less than 150, HDL more than 50 for women and more than 40 for men. And the another thing which I would like to add is the LDL cholesterol. If the LDL cholesterol hasn't got any atherosclerotic cardiovascular disease, then it should be less than 100. But someone who has got atherosclerotic cardiovascular disease with the diabetes, then the LDL should be less than 70. So what we manage in a holistic approach is the glycemic control, lifestyle modification, BP lowering, and dyslipidemia. These all factors together constitute the proper management of the diabetes. Now, lifestyle intervention, few slides more: exercise, nutrition, behavioral therapy, and follow-up. All these things together will lead to the long-standing good control of the diabetes. This is the food. We recommend that the fruit should be more, the vegetables should be more. This is the recommended diet for a diabetic person. But if you honestly look at our society, what we are eating this one. You go to any marriage, any party, majority of things we will eat all these things, but we always consider this is not fair. But these things should be encouraged. These things should be given to these patients, that they should have a healthy lifestyle. Then smoking, which is again injurious not only for the diabetes but actually for the cardiovascular disease also. So we quit smoking. Smoking to khatam ho gayi, shisha shuru ho gaya. So I think so, which is more injurious. But again, this is something which is state responsibility, that should take strict action against these shisha bars and all these things. But this is something which, being a doctor, we always discourage, that these things should not be there. Then spend less time sedentary. या तो हम सारा दिन मोबाइल पे बैठे होते हैं, we look at it, or we are in front of the television, which is again increases your sedentary time, which is again leads to the obesity and uncontrolled blood sugar levels. So if we look at this is actually, we eat 5 servings of fruits and vegetables. Number 2, 2 hours or less of recreational screen time, 1 hour or more of physical activity, and 0 sugary drinks. This is again something which is very important, not for us, for our young generation, that these fizzy sugary drinks, they are really something which is bad for your health. So please avoid yourself and discourage your younger ones to avoid from these sugary drinks. So last, again, something which is important, prevention is better than the cure. So prevent the obesity. What you will do, you are actually preventing the diabetes, you are preventing the cardiovascular disease, you are preventing actually the rheumatological problems in these patients. So a 30 minutes of exercise a day can reduce your risk of developing diabetes by 40%. So just 30 minutes of physical activity, keeping your weight in a normal BMI will reduce your chances of diabetes by 40%. So still, if you are young, I think so you can do that. This is 30 minutes is not a big deal per day, and that prevents you from these complications. So I conclude that the treatment always should be individualized, and every patient is a different patient. So there should be a patient-centric approach, and the cardiovascular safety should be on top. Whenever you prescribe a drug, we should know that it has got no cardiovascular side effect. Rather, it has got cardiovascular benefits, that the long term your patient will benefit from it. And we try to prescribe the drugs that will not cause the weight gain. So there should be no weight gain, and should be low risk of hypoglycemia in these patients. Thank you very much for your patient listening.
Thank you, doctor, for a very elaborative talk on a holistic approach to diabetes primary care perspective. Before we go to the second talk, I would like to invite our chairs. Again, Professor Dr. Ejaz Vohra. He is Professor Emeritus at Ziauddin University Hospital, ex-postgraduate Dean. Please welcome Professor Dr. Ejaz Vohra on stage. Thank you. Ask? Okay. It's fine. Thank you. So our next speaker for today is Dr. Ali Asgar. He is Assistant Professor of Endocrinology at Liaquat National Hospital. He is President-elect Pakistan Endocrine Society, and he will be discussing about transforming diabetes, power of lifestyle modification. Dr. Ali Asgar.
Hello. Bismillahir Rahmanir Rahim. Assalamu alaikum everyone, and thank you very much for being here on a Sunday. Thank you very much to PIMA, Pakistan Islamic Medical Association, for inviting me. My talk is on transforming diabetes, power of lifestyle modification, and how often do we talk about lifestyle? I'm grateful to PIMA for actually organizing the Diabetes Symposium and keeping a dedicated talk on lifestyle, because we talk very less about lifestyle, not only in our meetings, but probably also in the clinics as well. So disclosures, I have nothing to disclose. So do we practice what we preach? We tell patients about lifestyle, but do we actually do lifestyle ourselves? So all the audience sitting here, you should not be sitting here for too long. You should relax, get up. So I would request you all to please stand up wherever you are. आप लोग खड़े हो जाएं जहाँ पे भी आप हैं, please. Thank you very much. जाना नहीं है, सिर्फ खड़े होना है, ठीक है? So I'm just conducting a little exercise. I'll ask you questions, and those who say yes will actually sit down. So do we practice what we preach? So if you have a BMI, body mass index, between 18 and 27, please remain standing. If your body mass index is more than 27, if you're obese, please take your seats. You can sit down if your body mass index is more than 27. मैं देख रहा हूँ सबको, बाद में 27 से ऊपर खड़ा हुआ, तो I'll catch you, right? So whoever has a BMI, body mass index of more than 27, please sit down. Okay, अब जो लोग बैठ गए हैं वो दोबारा खड़े नहीं होंगे, ठीक है? अब जो खड़े हो गए हैं वो गेम में हमारे साथ हैं. Next is, if you sleep more than 7 hours every day, more than 7 hours every day if you sleep, please keep standing. If you sleep less than 7 hours, please take your seats and sit down. Thank you very much. जो लोग बैठ गए हैं वो दोबारा खड़े नहीं होंगे, ठीक है? That's, oh, a lot of people have already sit down, right? So okay, अब जो लोग खड़े रह गए हैं वो गेम में हमारे साथ हैं. If you eat 5 fruits, मैंने नहीं कहा, Dr. Saeed told in his presentation, 5 fruits and vegetables every day. If you eat 5 fruits and vegetables every day, keep standing. Otherwise, please take your seats, relax and enjoy on your seats. नहीं बैठ गए तो बैठ जाएं. जो बैठ गए वो पहले ही बैठ गए, वो गेम से आउट हैं, ठीक है? Few people are now standing. We have 2 more questions left, right? If you exercise 30 minutes 5 times per week, keep standing. Otherwise, please again take your seats. जो लोग हफ्ते में 5 दिन आधा घंटा वॉक करते हैं वो खड़े रहें, बाकी लोगों से गुजारिश है कि बैठ जाएं प्लीज. ओके, नहीं जो बैठ गए वो बैठ चुके हैं, दोबारा खड़े ना हो प्लीज. लास्ट क्वेश्चन, इफ यू डू नॉट स्मोक प्लीज रिमेन स्टैंडिंग, अदरवाइज प्लीज टेक योर सीट्स. Thank you very much for playing this game. आप लोग अपने इर्द गिर्द देख सकते हैं. Professor Saeed Meher standing here. The few of you just standing here. Give a clap to those who are still standing, please. But you see how difficult it is to actually have a good lifestyle. कितना मुश्किल है. We tell patients, but we realize that even we are unable to do this. 90% से ज़्यादा लोग इधर बैठ गए, and that's the power of lifestyle that we are actually missing, right? हम बहुत सारे पावर्स मिस करते हैं अपने मुल्क में, और ये पावर भी मिस किया, ठीक है? Okay, so diabetes dynamics, Professor Saeed and I always show these slides. 5th largest world population, Pakistan. Highest diabetes prevalence. 50% of the population is living below the poverty line. Last year inflation rate 23%. इतना cost बढ़ गई है रहने की. Just 2 days back, a woman was crying in my clinic because she couldn't pay her electricity bill. She was crying, and I don't know what to do. मुझे नहीं पता मुझे क्या करना है इस पेशेंट का. 90,000 उनका बिल था कि इलेक्ट्रिक का. कहने का मतलब ये people are suffering from the cost, but then we have something that is easier to do. This is American Diabetes Association, pillars of diabetes management: glucose control, blood pressure management, lipid management, agents of cardiovascular and kidney benefit. But look at the base. What is the base? Lifestyle modification. Most of the times we focus on medicines, patients focus on medicines, we forget what is the base, which is the lifestyle modification, right? And again, if you see the American Association of Clinical Endocrinology principles of diabetes management, look at the #1 principle. Lifestyle modification underlies all therapies in diabetes. And then this is the American Association of Clinical Endocrinologists algorithm for management of diabetes. They've got 2 algorithms. Complication-centric algorithm, look at what is at the top, lifestyle intervention. Again, this is another algorithm, glucose-centric algorithm for diabetes management. Look at the top again, lifestyle intervention. It is at the top of all guidelines. But when we focus on diabetes management, do we focus on lifestyle that much? Or do we have a dietitian who's going to do the lifestyle job and the doctor is going to give medicines only and insulin only? And patients, they focus on what the doctors say. They love their doctors. They want doctors to tell them what to do. They don't want to listen to others most of the time. Lifestyle therapy, what is meant by lifestyle therapy in diabetes? And we have not utilized lifestyle therapy much. I remember some 35 years ago, when I was a little kid, my grandfather was advising my father and my uncles what business to start. And I remember his sentence when I was a little kid. He was saying, "Khane peene ka business shuru karo, you'll never go in a loss." And I did not understand that at that time. But being an endocrinologist now, my grandfather was a wise man. He knew 30, 40 years ago what's going to come in future, right? And he's correct. In Pakistan, you open a food business, you're never going to lose anything, right? So again, nutrition, physical activity, sleep, behavioral support, and smoking cessation. So in nutrition, of course, calorie restriction if there is obesity or overweight. Then plant-based diet, more high polyunsaturated and monounsaturated fatty acids in the diet. Physical activity, as Dr. Saeed also said, 150 minutes per week, moderate exertion like walking. Sleep is very important. We just don't take sleep so seriously. हम तो सोचते हैं भाई सो जाते हैं तो नींद पे हमने आसान कर दिया कि थोड़ा सो गए. The busy work professionals, right? Sleep, more than 7 hours of sleep is extremely important to control diabetes. Behavioral support, engaging the community in talking about lifestyle, right? And again, smoking cessation, no tobacco products, right? जब भी टोबैको की बात आती है हम कैंसर, लंग कैंसर की बात करते हैं. ये बात नहीं करते कि टोबैको डायबिटीज को कितना इम्पैक्ट करती है. Again, ACE recommendations for therapeutic lifestyle changes. Reduce your diabetic patient's weight by just 5 to 10% at least to control HbA1c if the patient is overweight or obese. And studies show that 90% of diabetics, they are overweight or obese, right? Again, physical activity and diet, और मैं इसके बारे में बाद में भी बात करूंगा. A negative energy balance is very important. What you are eating the entire day, are you actually using that? Because you are not using what you are eating, it's going to go into the stock, create obesity and difficult in managing diabetes. Importance of 24-hour physical behaviors. It is so important. हम बहुत सारी चीजों पे focus करते हैं. What the American Diabetes Association says, it's a 5S approach, right? First of all, sitting. Breaking up prolonged sitting. So if you're sitting more than 30 minutes, just get up, walk a little bit, maybe just do a stretching exercises and sit down. And that is what I did in the start of my presentation. I helped you breaking that sitting environment that you had, right? Stepping. An increase of only 500 steps per day is associated with 2 to 9% decreased risk of cardiovascular mortality. आप 500 steps extra चलते हैं, 9% cardiovascular disease mortality कम हो जाती. Just 5 to 6 minutes brisk intensity walk per day. 5-6 minute walk कर लें, brisk walk. The life increases by 4 years, the lifespan. I mean, this is all what research has shown. मैं अपनी तरफ से नहीं बता रहा. Sleep, 7 hours of sleep, more than 7 hours of sleep, increases your diabetes control, makes your diabetes control better, reduces your HbA1c. Sweating, more than or equal to 150 minutes of walk every week, again helps you control your metabolic profile. And strengthening exercises like going to a gym, weight trainings, again helps control diabetes. So 5S approach. And what does the 5S approach do? Now look at this. These green arrows are where there is very strong evidence, right? This is American Diabetes Association, just to let you know. Sitting, breaking up prolonged sitting decreases your glucose concentration. Decreases your glucose. Even if you are a normal person, the glucose will go down. If you're diabetic, the glucose will go down. And then stepping. Again, stepping, you reduce your glucose in the blood. Sweating. Now, if you're sweating, you're doing moderate to vigorous activity, 30 minutes of walk every day, 5 days a week, you reduce your glucose concentration, blood pressure, A1C, lipids, physical function goes up, depression goes down, quality of life goes up, just by walking half an hour every day. Now we focus this is such an easy thing to do. Again, if you see effects of aerobic exercises on A1C in pre-diabetes, even in pre-diabetes, A1C reduces. These are all the studies that shows A1C reduces by around 0.4 to 0.5% in a pre-diabetic if he's doing aerobic exercises. And this is the European Association for the Study of Diabetes, EAST 2020, in the Diabetologia, which is their journal. This is what exercise does. Professor Meher showed us how diabetes works with all the 8 pathologies, right? Look at exercise, how it helps all these pathologies. Look at the beta cell function, which increases with exercise, more insulin production. Look at liver, where there is increased insulin sensitivity, increased glucose uptake, the blood vessels, where there is increased flow and increased delivery of oxygen, the muscles, where there is increased muscle mass, increased insulin sensitivity, increased glucose uptake, better function, muscles get strong, right? Again, the heart, the resting heart rate goes low. Other day I was sitting with a cardiologist who's a heart rate specialist, rhythm specialist, and I asked him, what is the best heart rate to reduce cardiovascular morbidity and mortality? And he said, keep the heart rate between 50 and 60. When we exercise, we improve our heart's function, and the basal heart rate goes down. the blood pressure goes down as well. Again, for the fat cells, it decreases the adipose tissue depots, increases insulin sensitivity, and increased glucose uptake. And overall, what is the impact on health? Now, this is evidence-based in the European Society, European Association of Study of Diabetes. Look at on the far right, decreased insulin resistance, decrease in type 2 diabetes incidence, decrease in the MASL, which is the liver disease, the fatty liver disease, decreased cardiovascular disease, reducing the metabolic syndrome, reducing the obesity, and reducing the mortality. I mean, what else we want in a diabetic patient? What we want with diabetes? We want reduced complications, reduce the morbidity, reduce the mortality. So why not lifestyle first? And why not lifestyle with a vigor and with an energy, right? Again, 150 minutes is the magic number. You have to do 150 minutes every week. Now, whether you do 50 minutes thrice a week, or 30 minutes 5 times a week, or you break it. Studies say that if you can't do 30 minutes in one go, people say, doctor, we can't take out time. Take out 7 minutes 5 times a day and do it. Complete that 30 minutes. Remember, 7 minutes of brisk walking increases your lifespan by 4 years, the study says. So do that 30-minute walk. हम सोच में पड़ जाते हैं 30 मिनट कहाँ से निकालेंगे, टाइम ही नहीं है, इतने बिजी है, तो 5-7 मिनट निकालते चले जाएं दिन में 3-4 बार. Again, what is the METs, metabolic equivalent? So when somebody is at rest, we consume 1 metabolic energy, right? For example, then slow walking consumes 3 METs. Walking upstairs, 4.7 METs. Brisk walking, 5.4 METs. Bicycling, 7 METs. Running 8, hockey 12, and boxing 13. But we can easily do brisk walking and increase the metabolic rate of our body by 5.4 times for the resting rate and increase the oxygen consumption and calories that we have. You are what you eat. I mean, we have got so many hadiths saying we are what we eat. So many hadiths are linked to what we eat actually makes us. Evidence-based European recommendation for the dietary management of diabetes. Now just see this. European recommendation, again last year, Diabetologia, important messages are to consume minimally processed plant foods such as whole grains, vegetables, whole fruits, legumes, nuts, seeds, and non-hydrogenated, non-tropical vegetable oils while minimizing the consumption of red and processed meats, sodium, and sugar beverages. I mean, we all know this. It's very simple. If we don't go into the nitty-gritties, it's pretty simple. We need to avoid sugary items and meat and processed food. The diabetic plate, it's very important that we understand it cannot be a plate of rice only. It cannot be a plate of bread only. It has to be divided. There has to be vegetables, fruits, grains, proteins, and dairy. And low-fat dairy, of course, low-fat protein. It has to be a mix of diet. Remember, we don't eat because we only love it. This is God's beauty that is given. He has given us love to eat so that we actually eat. A car runs on petrol, a human runs on food. We have to take food to have energy. लोग कहते हैं carbs को बिल्कुल low कर दो जैसे keto diet में होता है. We need carbs. Our brain need carbs, right? It's difficult. It's the other thing that we need. 45% carbs are needed in a diabetic person, but it has to be complex carbs with reduced rate of absorption. The Mediterranean diet again, this has been shown to be for now the best diabetes diet that you can have. Look at the lower end of the pyramid. More whole grains, bread, beans, legumes, nuts and seeds, fruits and vegetables, and then olive oil, fish. And as you move to the top, little of sweets and meat. Okay? So this is what we need to understand. Now, we all go through this every day, but it becomes a challenge. Now, I had to go to a birthday of my Sala's daughter, and there was cold drink, and there was cake. And when I refused, I don't want to eat cake, my wife said, "ये साली ने आपकी बनाया है." अब वो एक अलग मसला कि आप मना करेंगे तो भी फंस जाएंगे. In our society, it's very difficult to say no in these things. People mind it. आप मेरे घर आएंगे, मैं कहूँगा ये तो लेना पड़ेगा वरना तौहीन समझी जाएगी. भाई डॉक्टर साहब ने ऑफर किया, गुलाब जामुन रख दिया, आप घर गए थे और नहीं खाया, पानी पी के आ गए. In our society, it's very difficult to control diet, but we have to change things being healthcare professionals, right? Again, look at the effect of Mediterranean diet on mortality. many studies showed that regardless of what it's diabetes or no diabetes, Mediterranean diet reduces mortality and cardiovascular mortality. Whether you are smoker or a non-smoker, it helps. And again, there is a lot of discussion, which diet to take. Should we take a Mediterranean diet or should we take a low-fat diet? Whatever diet you take will reduce weight, but it has to be consistency. आप लोगों में से कितने लोगों ने सुना है cheat day? Cheat day कितनों ने सुना है? मैं तो पढ़ता रहा, मुझे तो cheat day नहीं मिलता. हमारे यहाँ cheat day, हमारे यहाँ हर चीज cheat पे बस cheat. Cheat day, what is a cheat day? ठीक है? So many guidelines will suggest it has to be a consistent diet. Just carry on with the diet every day. आप 6 दिन मेहनत करके 7 दिन आप सब कुछ खा के तबाह कर दें, बर्बाद कर दें, ठीक है? That's not how you go about it. It has to be a consistent diet. Intermittent fasting and the beauty of the month of Ramadan, and there are many hikmat in the roza that Allah has made obligatory upon us, but intermittent fasting, there are so much data on intermittent fasting. For example, studies show that if you have a 10-hour time restricted eating and you don't take anything for the next 14 hours, you start to lose weight. You start to control diabetes and blood pressure and cholesterol, even with the normal diet that you are taking, right? Time restricted eating or intermittent fasting. लेकिन हमारे यहाँ क्या होता है रमजान में? हम पूरा दिन रोजा रखे हुए, हमारी इफ्तार होती है, उस पे स्टडीज होती हैं, and there are mixed studies. People have lost weight, people have gained weight in Ramadan, ठीक है? ऐसे भी लोग आते हैं जिनका रमजान में वेट बढ़ जाता है. Professor Islam would agree, would probably second कि रमजान के बाद कितने लोगों का A1C बढ़ जाता है, ठीक है? वो इफ्तारियां ऐसी होती हैं और इस पे डिटेल टाइम नहीं है, वरना मैं मजीद भी बात करता. So again, the same slide that Professor Said showed, we need to shun this dark, brown, uncolored diet. हमारी conferences में भी तो ऐसी diet होती है. And I remember once there was a conference जिसमें शोर हो गया. भाई रिकॉर्ड नहीं कर लेना इसको, ठीक है? Conference में healthy diet थी और वहाँ it became a problem. There was resistance on part of health professionals कि भाई ये क्या खाने में रख दिया हमारे लिए, ठीक है? So it is a difficult task to change lifestyle, but we have to start from one point and start doing it then. This is the colorful diet that we need to be having. So now the time is for type 2 diabetes remission. This is something that has given a lot of hope to us, a lot of hope to patients. So again, in patients with type 2 diabetes and obesity, weight loss of around 15 kilograms can lead to a remission of type 2 diabetes in 80% people. And studies have clearly shown that as weight goes up, the chances of diabetes goes high. As weight goes low, the chances that diabetes will come in goes low. And look at this. This is the weight gain that you have. If a diabetic has 5 to 10% weight loss, remission chance is around 30%. And if a diabetic person who's overweight or obese loses 15 kilograms of weight, there is 80% chance that he will go into remission of diabetes. But this is just remission. लोग कहते हैं बस हो गया डॉक्टर साहब, अब खाएं पिएं. No, it has to be a consistent diet. मैंने नमाज 5 बार पढ़नी है तो 5 ही पढ़नी है कि इंशाल्लाह आखिर तक. तो कहने, the whole point it has to be consistent. We can't lose the pot, right? Again, quit smoking. Now smoking is injurious to health. और वो डब्बे पे इतना बड़ा कैंसर का लोगो आ गया है और हमारी प्रायोरिटी ये है कि इतना साइज होना चाहिए उसका, ये कैंसर वाले मुंह का. लोग तो नहीं रुके स्मोकिंग से, ठीक है? We have to mobilize people. I always say, जब हम मीडिया खोले तो वही politics. क्यों हम मीडिया नहीं खोलते हैं तो ये बातें नहीं होती हमारे सामने. We can change things. I mean, we can make our own channels to propagate these things. 30 to 40% increased risk of diabetes with smokers. And the more you smoke, the more the chances of getting diabetes. And same goes with diabetic people. You quit smoking, you reduce your smoking, and you control your HbA1c. You don't need to come back to us again and again to control A1c then. Plain water intake. And water, pani mein shifa hai, hum sunte. The latest study, 2024, says plain water intake prevents diabetes mellitus. I mean, the more water you take, through a lot of molecular mechanisms, they have seen that in normal people who don't have diabetes, the blood glucose levels significantly drop only by taking a certain 8 to 10 glasses of water per day. This was 3 liters per day in this study. Such an important aspect, water. But we say कि प्यास लगेगी तो हम पिएंगे, ठीक है? So water has healing powers, right? Why miss these powers? Sleep. 250,000 participants, this is a British registry, and though they saw that individuals sleeping less than 6 hours daily had a notably higher risk of developing diabetes compared to those having 7 to 8 hours of sleep per day. Such an important component. सोने में जब हम कुछ नहीं कर रहे होते हैं, उसमें भी हिकमत ही हिकमत पोशीदा है, ठीक है? Thank you very much. I think it's time that we start working on lifestyle management. Thank you very much.
Thank you, Dr. Ali, for a very wonderful talk on transforming diabetes, power of lifestyle modification. So our next speaker is Dr. Aisha Sheikh. She is consultant endocrinology at Aga Khan University Hospital. She is President Pakistan Endocrine Society. Please welcome Dr. Aisha Sheikh. She will be discussing cutting edge innovation in diabetes.
Bismillahirrahmanirrahim. Assalatu wassalamu ala khatamin nabiyyin. Assalamu alaikum. Thank you very much, Dr. Awais, for a nice introduction, and I'm really grateful to PIMA for inviting me for this talk. And I'm humbled to present in front of the great teachers, Professor Ijaz Vohra and Professor Najmul Islam. So, can I have my slides? And thank you, my former speakers, Dr. Saeed Meher and Dr. Ali Asghar, for making my life easy, because you have discussed quite a lot, and I can focus more on the cutting edge innovations in diabetes management. So as we have already discussed that diabetes is a complex chronic illness that requires continuous medical care with multifactorial risk reduction strategies beyond glycemic control. And there is significant evidence that exists to support a range of interventions to improve diabetes outcomes. Diabetes is on the rise, so more than 546 million people worldwide have diabetes. In Pakistan, you can see with 33 million people with diabetes stands number 3. And the two countries which are above us are actually those countries which are already have huge populations than ours, placing us in terms of percentage on the top rank. Diabetes leads to cardiovascular disease, kidney failure, blindness, and lower limb amputations, and these are the hard outcomes that actually we want to avoid when we are managing our people with diabetes. Causes of death, heart disease stands the highest percentage, 68%, strokes another 16%. And this is the pathogenesis of type 2 diabetes, where there are multiple defects at different levels of our system. And therapies are actually trying to focus those areas of defect, and thus therapies have been evolved over last a decade or so remarkably, that had led to a paradigm shift in diabetes management. When it comes to type 2 diabetes, a patient, well, by the time the patient develops diabetes, they have already lost 50% of their beta cell mass, and that loss actually continues over progressive years, which means that diabetes is a progressive disease, and whatever therapies you start at point 1 may not be effective by 2 years down the line or later on. Thus, the therapy of type 2 diabetes has to escalate, and as Dr. Ali Asghar has already pointed out, that lifestyle therapy is something that forms the basis of diabetes management throughout the course of a patient's life, and then oral monotherapy, oral combinations, and then you progress to injectables, which are incretin mimetics, and then insulin treatment is needed in many people with type 2 diabetes. So my question to you is that what is true regarding incretins? Can we have a show of hands? So it releases insulin independent of glucose levels. How many think that this releases insulin independent of glucose levels? One hand over here. Increases glucagon levels? None. Works at the GI tract alone? Approved as anti-obesity medications? Can we have a show of hand? What is true regarding incretins? And only available as injectables? Okay. So this is actually true regarding incretins. We know that incretins release insulin dependent of glucose levels, so they are glucose dependent insulin release. They reduce glucagon levels. They work at various sites, central nervous system and GI as well. And they are approved as anti-obesity medications, and they are available, at least one formulation is available in an oral form as well. So incretin effect, you have been listening to this effect for last, I think, a decade or so. Incretin effect is something when you are taking glucose through the oral route compared to if you are taking it through an IV route. The level of insulin response is remarkable through the oral route. And those are the incretin hormones, which are GLP-1 and GIP. And incretin-based therapies are GLP-1 receptor analogs and then DPP-4 inhibitors. DPP-4 inhibitors will actually break the enzyme DPP-4, which inactivates the endogenous GLP-1, and GLP-1 receptor antagonists are those analogs which are mimicking the GLP-1 receptor, GLP-1 native GLP-1, and thus are leading to various effects that improve glycemic control and other parameters as well. What was interesting is that these molecules were found to improve the major adverse cardiovascular events. The major adverse cardiovascular events that include non-fatal MI, non-fatal stroke, death from cardiovascular diseases, and heart failure hospitalization. And this is meta-analysis, a recent one from all the trials which were looking at the cardiovascular outcomes of GLP-1 receptor analogs, and you can see that these are favoring GLP-1 receptor analog compared to placebo. Similarly, the renal outcomes, a composite of renal outcomes that include reduction in eGFR levels, need for renal replacement therapy, and renal death, death from renal causes, all were shown to improve through these GLP-1 receptor analogs. And then there are newer agents in the pipeline. You must have been aware of dual GLP-1 GIP analogs, which is available by the name of tirzepatide, already been approved for type 2 diabetes and as an anti-obesity medication. And then there is work going on triagonists, which are GLP-1, GIP, and glucagon triagonists. There are molecules which are underway. You can see that dual agonist is already marketed, but the triple agonists are under phase 1 clinical trials. Okay, so coming to the other agent which is in use in clinical practice, the SGLT2 inhibitors. And these are novel agents in which do all of these except. So one of these is false. Can you identify which one? So A, these lead to glycosuria and natriuresis. These lead to insulin independent action. They lead to weight loss, and they enhance cardiovascular risk, and they lead to reduction in albuminuria. So what is false in all these statements? Enhanced cardiovascular risk. Thank you. So these do not lead to enhanced cardiovascular risk, rather lead to improvement in cardiovascular risk scores. This is the normal glucose homeostasis in our kidney. 180 gram of glucose is filtered per day, and all of this is actually absorbed by these transporter proteins, SGLT2 transporter protein and SGLT1 transporter protein. And virtually in a person who is not having diabetes will not be releasing any glucose excretion in the urine. What happens in people with type 2 diabetes is that these transporter proteins are upregulated, and kidneys are actually hyper-absorbing glucose. So this threshold moves on to something like 220 gram of glucose. And thus, if you could just block this transporter protein, SGLT2 transporter protein, you can actually increase glycosuria, but at the same time lead to reduced glucose reabsorption and improve glycemic control. And these are the agents which are working independent of the beta cell function. So whatever insulin reserve or insulin resistance a patient has, these molecules will continue to work because these are working at the kidneys. And thus, SGLT2 inhibitor, the CVOT, the cardiovascular outcome trials have shown many beneficial outcomes in terms of reducing the major adverse cardiovascular events, similarly reducing the risk of hospitalization for heart failure and cardiovascular death. All for empagliflozin, canagliflozin, dapagliflozin, there are trials. And then if you look at the life expectancy in people with diabetes, and this is something which is already discussed by Professor Saeed Meher in his talk, diabetes reduces the life expectancy. If a person with diabetes has coexisting cardiovascular disease, there would be a further reduction by 12 years, and with diabetic kidney disease by 16 years. And if we could just have therapies that improve those outcomes, and you can look at SGLT2 inhibitor trials on renal function worsening. These are again all the major SGLT2 inhibitor molecules that are available, and cardiovascular outcome trials have already been done. And these are the renal outcome trials, and all of these show that they improved renal function, reduced the risk of end-stage renal disease or renal death as well. This is again a trial by on heart failure hospitalization. These were the trials which are specifically dedicated to diabetic and non-diabetic individuals, and showed that these agents reduce the risk of heart failure hospitalization and reduce the cardiac death as well, both for empagliflozin and dapagliflozin. And similarly, empagliflozin on heart failure hospitalization with preserved ejection fraction. So this was something which we label as diastolic dysfunction. There weren't any specific therapies that could improve the outcomes, but empagliflozin eventually showed through this trial that there was almost a 21% reduction in the primary outcome of cardiovascular death or heart failure hospitalization. Thus, these agents have been registered and approved for use beyond glycemic control and beyond benefits for type 2 diabetes, even for people who do not have diabetes with cardiovascular disease and heart failure. These agents are approved for use. Important to note that you cannot use these agents in type 1 diabetes and somebody who is at risk of diabetic ketoacidosis. And similarly, okay, so this recommendation has actually changed. And it has been approved for chronic kidney disease as well, based upon the recent EMPA kidney trial. Similarly, dapagliflozin, beyond the use of in type 2 diabetes, it has been approved for use in heart failure hospitalization patients to reduce the risk of heart failure hospitalizations. Similarly, reduce the risk of cardiovascular death and hospitalization for heart failure in people with reduced ejection fraction, and for somebody who is having kidney disease, irrespective of the diabetes status. So these have wider implications and indications in people with or without diabetes who have underlying cardiovascular disease or kidney disease. And there are emerging data that suggest that in people with fatty liver disease, these agents are beneficial, and we will be coming up with more such trials that are published and will show the improvement in and metabolically associated steatotic liver disease as well. And this is something that Professor Saeed Meher has already discussed. Goals of care in managing people with diabetes is to improve their quality of life and reduce the risk of complications and prevent the complications. And you need to look at the patient comorbid. So if the patient is having a chronic kidney disease or heart failure or a cardiovascular disease, your agent of choice after metformin would be either an SGLT2 inhibitor or GLP-1 analog therapy. Then coming to what is happening on the scene of insulin, especially with regards to people with type 1 diabetes who are absolutely insulin deficient, we have got ultra long-acting insulins available in market. These are insulin degludec and U300 insulin glargine, which have a very stable curve beyond 24 hours of coverage. And similarly, there are ultra-rapid acting insulins available in different markets in the West. We still do not have those, but those are ultra-short acting insulins available as well. Then glucose meters. When it comes to managing people with diabetes, especially those who are on insulin, people with type 2 or type 1 diabetes, we all know that glucose meters are a major technological advancement that occurred in past few decades. And it leads to helps the patient and the healthcare provider to make treatment decisions and modifications, can help them identify what kind of impact they are having in terms of their diet and exercise on their glucose levels, treatments, and how to adjust those treatments. Similarly, identification of hypoglycemia in a timely manner as well. So there has been advancement in when it comes to monitoring of blood glucose levels. So can any one of you identify which place is this, which is hidden behind these bars? Which place is this? Can anyone identify? No, it's difficult to identify? Okay, so let me share some more part of this scene. Can anyone now identify which place is this? Okay, so this is it. This is Paris, and you can see that if we are having self-monitored blood glucose alone, we can actually miss highs and lows. So this is the data. You can see the patient is testing his blood glucose values at these 4 points in time. And all those 4 values are actually well within the range. But when it comes to unnoticed highs and unnoticed low, those are not evident on these glucose monitoring devices. So you can see that when we come to an A1C value, we rely a lot on A1C values for patient treatment and management. A1C of 7% could have many faces. A patient with A1C 7 would be this patient who is falling 100% of the time in range. So this would be that patient who is just treated with metformin and following all those lifestyle factors that Dr. Ali Asghar has pointed in his talk. Or a patient could be 70% of the time in range, 25% high, 5% low, and such kind of curve is there on his CGM. Or a patient could be 40% in range, 20% low, 40% high, but still having 7% A1C, which means that for many patients, A1C alone will not be a good tool, and even self-monitoring blood glucose alone through glucometers will not be a good tool to definitely tell us what is happening to that patient. And thus there is role of CGM devices, the continuous glucose monitoring devices. A few devices are available for our use in Pakistan as well, and these are devices by Libre, and then these are Medtronic, Abbott, and Dexcom devices. And this is something which is kind of a new thing. This is implantable CGM device which can give you data over next 6 months. So these are technological advancements. Right now they are costly, but over years we all know that technology, when it comes for the first time, it's costly, but over time the cost goes down, and more people will benefit from it. Similarly, this is the mechanism. So these devices are actually testing glucose in the interstitial fluid, and this is called as sensor glucose values. And then these are the insulin pumps, continuous subcutaneous insulin infusions that are a very good device for people with type 1 diabetes, where they can ensure 80% time in range. Different devices are available from Medtronic, these are the tubeless pumps which do not require a tubing inside the skin. So you can see that over here there is a tube and the insulin reservoir, and the insulin is delivered through that tube. This needs to be changed every 3 days. And then these are the bionic pancreas systems, which are having both insulin and glucagon chambers available, and these are something that will be trying to mimic what is happening through our pancreas, the normal pancreas. And then these are again some advances that are happening, and these insulin patches, smart insulin patches, will be undergoing clinical trials from next year. These have micro needles which contain insulin loaded in the polymeric matrix, and this is responses. This is assessing glucose through the glucose oxidase method, and will only release insulin in response to a high glucose level. So the fear that we all have when we are prescribing insulin to our patients is hypoglycemia. And these insulin polymers will actually ensure preventing those hypoglycemias, because these will be releasing insulin only in response to a certain glucose level. So these are glucose responsive, and this will be a small device, a nanotechnology that will be in use. Similarly, once weekly insulin is something that is talk of the town as well. It is still awaiting its FDA approval, but once weekly basal insulin is in formulation. It will be hearing more about this in upcoming months and years. Again, a new advancement that is happening in research settings is insulin islet cell transplantation for type 1 diabetes. Islet cell transplantation is something when you have a non-diabetic disease donor, and the islet cells are acquired from that pancreas, and then through the portal vein in the recipient of type 1 diabetes, it can be transplanted. People can have 2 times islet transplantation, and that have improved many parameters of people with type 1 diabetes, especially those who have brittle diabetes and very fluctuating glycemic controls. So, and last but not the least, you might have been hearing and coming across patients who are saying, "Doctor, there's one injection that cures diabetes. Can you give me that injection?" So this is teplizumab, which is not for everyone who is having diabetes. Even for type 1 diabetes who already have diabetes, this will not work. This is a monoclonal antibody that is approved for treatment indicated to delay the onset of stage 3 type 1 diabetes in people with stage 2 diabetes, type 1. So for type 1 diabetes individuals, those type 1s whose families have already been screened and they are found to be having islet cell auto antibodies in their systems, and you keep on monitoring them with a glucose tolerance test looking for whether they are having pre-diabetes, and then they will progress to type 1 diabetes. So that stage 2 type 1 diabetes is something which we understand pre-diabetes in people with type 2 diabetes. So only for those individuals who have islet cell antibodies and who have pre-diabetes, you can use this teplizumab, which will delay the onset of type 1 diabetes by almost 3 years. So 3 years benefit they can get by delaying their type 1 diabetes onset. So this is my take-home message. The latest anti-diabetic agents have demonstrated enormous cardiovascular and renal benefits through the pleiotropic effects, and these are the effects beyond glycemic control. So these drugs were designed to improve glycemia, but later on were found to be beneficial in cardiovascular outcomes and renal outcomes. The management of type 2 diabetes has actually moved away from a glucose-centric approach to an approach that targets comorbidities and cardiovascular and chronic kidney disease risk reduction. And thus the role of GLP-1 analogs and SGLT2 inhibitors need to be emphasized further. Major advancements in monitoring and insulin delivery systems are revolutionizing the care of people with type 1 diabetes, and there is hope for delaying the onset of type 1 diabetes in people with stage 2 disease. Thank you very much for your patient listening.
Thank you, madam, for a very elaborative talk on newer innovation in diabetes. We have time for 2 to 3 questions. If anyone has, please raise hand. Okay. Either mic.
The cost of the transplantation of islets of Langerhans, what is the cost and where it can be done?
Okay. So, madam, we have question for you. इधर स्पीकर एक स्पीकर और दे दीजिए, माइक एक और दे दीजिए.
Can you repeat the question?
Can you please repeat the question?
Dr. Ataur Rahman, Quetta se. May cost of the transplantation of islets of Langerhans and where it can be done here in Pakistan?
No, islet cell transplant is not available in Pakistan. As I already mentioned that this is in research labs, only done in research labs. So it's available in centers which are dealing with clinical researches on these transplant technology. Only over there those are available. These are not available in Pakistan.
Okay, thank you. Any other question? एक इधर से भी है.
डॉक्टर अली असगर साहब से सवाल है कि एक्सरसाइज से हार्ट रेट बढ़ता है, लेकिन आपने कहा कि बेजल हार्ट रेट कम हो जाता है, तो थोड़ा सा एक्सप्लेन करेंगे कि बेजल हार्ट रेट कैसे कम हो जाता है?
Dr. Malik Sheikh, first of all, thank you very much for coming from Matli. It's a pleasure to see you. So you give more stamina, right? So heart more, and with that muscular strength, it can maintain a heart rate which is lower than what it is actually to maintain that cardiac output. So it's you're remodeling your heart towards becoming stronger and giving a lower heart rate with exercise. So it's basically building up the stamina, making it stronger, to keep it simple.
एक यहाँ फीमेल सेक्शन,
Dr. Ali Asghar sir, thanks for delivering nice demonstration to us. Sir, my question is belonging to the mode of life is totally changed. We all are on the rides, on convents. While the handi is same, the way we cooking in our Pakistani homes, the handi is on ancient way still. So why not we change our handi so that we can cope up with this modern era and modern life? Thank you.
I couldn't understand. What should we change?
Lifestyle is same. Okay, sir. The handi is same. The way we cooking, our cooking system is ancient. From forefathers. Okay, sir. The lifestyle is changed. We are on the rides, we are on motorcycle, we are on bike. We have no exercise, no walk. Why should we either we change our lifestyle or change our cooking style?
I think...
Thanks.
So, let me reply that. So we have changed a lot. I mean, when I was a kid, we used to walk 8-10 kilometers every day. And now the general store is just hardly 300 meters from my house, but I cannot go there. There are a lot of dogs sitting on the corner of the road, and I'm too afraid of dogs. So I have to take a car to just ride 300 meters to buy something from the general store. And आप लोगों ने सुना होगा animal rights, right? Forget about human rights, animal rights. So उन्होंने कहा जी ये dogs तो हम यहाँ से नहीं हटाएंगे. There are animal rights in Pakistan. So, well, humans have to suffer then. So the whole point is that we have changed in our lifestyle. Yes, we are not walking as much as we were. We are taking a lot of processed food. How many homes are using the mobile applications to call food in? पहले तो एक घर में एक बार आता था खाना, अब तो सबकी अलग-अलग choice आती है. किसी का खाना इधर से आ रहा है, किसी का उधर से आ रहा है. The way of cooking when I was in UK, मुझे याद है पैसे तो होते नहीं थे, बगैर तेल के खाना बनता था. और हमारे यहाँ ज़्यादातर, हमारे घर में तो नहीं, लेकिन आप देखें खाने के अंदर यूँ डाल के देखना पड़ता है कि अंदर है क्या तेल के नीचे. So, I mean, we cannot blame anybody. हम किस को blame करेंगे? हमें एक step लेना है, अपने घरों से ही start करें, ऑयल को कम करें, मीठी चीज़ों को कम करें, बाहर के खानों को कम करें, अपने आप को बदलें, बच्चों को बदलें, लाइफस्टाइल में चेंज लाएं. For example, I can't go to walk anywhere else, but I tend to walk in my own parking area, which is a good area. तो हर एक के पास कोई ना कोई जगह होती है, कोई टीवी लॉन्च है, कोई पार्किंग एरिया है, कॉरिडोर है, छत है, आपकी गली है, कहीं ना कहीं. So we have to make a point to change. जो cooking style है, most of the women cook, men भी cook करते हैं. I mean, we need to sit down as a family. मेरे घर में 7 दिन चावल बनते थे, हमने बचपन से चावल खाए हैं. लेकिन हमने देखा कि नहीं, अब वेट बढ़ रहा है, मैं वाइफ हम बैठ गए, हमने कहा बस अब हफ्ते में 1 दिन चावल बनाएंगे, इससे ज़्यादा नहीं खाएंगे. We can't eat. कि जिस दिन राइस खाते थे लगता था कि I mean, we are getting bloated, right? So we reduced rice, we reduced oil, we reduced sugar in our own homes, right? And this is when we have to change from our own households and then bring that change in the society as well. So I agree with your point, yes. Thank you.
जी बोल.
Okay, so my name is Mariam. I'm a medical student, and my question is directed towards any of the consultants, whether it be Dr. Saeed, Dr. Ali, or Dr. Aisha, who seems fit to answer the question. So in the current healthcare trends, drugs like semaglutide, I'd rather say infamously known as Ozempic, is all the rage these days for weight loss reduction. Do you think this kind of a trend would pick up in a country like Pakistan, where even though these drugs are expensive, they might become mainstream media for, rather than lifestyle modification, we'd be switching to drugs like these for obesity or weight loss management? Thank you.
The question, beta, which I have understood, I absolutely agree with you. In my talk, in Ali's talk, in Dr. Aisha, we all always say that drugs are not the solution for everything. We are not a very affluent country. We are poor people. Again, if we can, whatever the drugs may be, which reduces the weight, which is again not natural. So if we effort ourselves, what Ali said, it's 30 to 40 minutes exercise per day. Reduce your diet, decrease your caloric intake. You can reduce the same amount of weight without any medications, except in few cases where there are other endocrine problems. Then I agree with you, then you need the assistance. But majority of the cases, we can do all these things without these fancy medications. So this is medications are not for everybody. We are here not to promote the medication, but we are here to promote actually a healthy lifestyle. Thank you.
Thank you very much. So with this, I would like to invite the chairs for their final comments, and Professor Dr. Ejaz Vora and Dr. Najmul Islam.
I'll give my comments first, and then I'll ask Dr. Ejaz Vora to give his final comments. I mean, this session was, first of all, I would like to thank the PIMA for inviting us for this session and organizing this session on diabetes mellitus. Saeed has given a good overview of diabetes for the general practitioners, and he has nicely covered all aspects of diabetes. Ali Asghar has stressed in a nice way about the importance of lifestyle modification and the benefit that you get out of it and how to achieve that. And Dr. Aisha Sheikh has covered the new developments in the field of diabetes, the new medications and new gadgets. So, I mean, they have covered all the things which are important for the prevention of diabetes and for the management of diabetes in a most effective way with preventing the complications. I just have to compliment them for their talks which they have given and covered all the aspects. And as an addition thing that I would like to add here, that we are number 3 in the world in terms of diabetic population, 33 million. We used to be number 11, then we became number 7, and now we have become number 3. We are not likely to become number 2 or 1 because of the two other countries that we are competing with have got a huge population. So we're going to remain number 3. But I hope we do something to come down to number 5 and number 6 rather than going up further. So that is something that we should be stressing on, the prevention of diabetes. And for that, lifestyle modification, keeping our weight in the range is the way to go. And for that, we need to have a less food intake and more physical activity. और ये चूँकि इस्लामिक मेडिकल एसोसिएशन का प्रोग्राम है, तो मेरा कहना था कि हुजूर अकरम सल्लल्लाहु अलैहि वसल्लम के तरीक़ा खाने का ये हुआ करता था कि वो 1/3 खाते थे, 1/3 पानी और 1/3 खाली छोड़ते थे. तो अगर हम लोग इसको अडॉप्ट कर लें, खुराक अपनी कम कर लें और ज़्यादा खाना और पेट भर कर और डट कर और खूब वैसे खाने का जो तसव्वुर है वो ख़त्म कर दें अपने, उससे तो फिर मामलात काफ़ी हद तक बेहतर हो जाएंगे. तो ये तो मेरा कमेंट था. मैं फाइनल कमेंट्स के लिए डॉक्टर एजाज वोरा को देता हूँ.
Thank you. Thank you organizers for honoring us with this on this session. I think we had excellent talks, and from Dr. Saeed Meher, I particularly would like to one point. There is a therapeutic inertia that is due to physician. So I think when we are dealing with a patient, we must emphasize that early intensive control will prevent complication. And delaying insulin, if it is needed, I don't think is the right step. So first of all, our own inertia, we should do something. The physicians are more active. And of course, in Dr. Ali Asghar, in his dynamic style, they give the importance of lifestyle management. The point is, in these economic conditions, how can they afford? A survey was done some years ago. A large number of population even can't afford once a week fruit or vegetable. So I think then we also have to think of measures by the government. You see, we must have tax these cold drinks. They should not be 250 ml. In New York, they don't allow large. So in Pakistan, every day there is a advertisement, 250 ml, 300 ml. So I think these sugary drinks we must control. And of course, opportunities for exercise. Maybe if Dr. Ali Asghar, we can break up 10 minutes 3 times a day. It will give you a half an hour. And if a good method to stand After 40 minutes, you must get up from seat and stand. And then I was talking about government initiative. Trans fatty acid should have been eliminated by the year end of 2023. We still have trans fatty acid in our vegetable ghee. All bakery products are trans fatty acid. I think government should take action. We as an association also must make a plea so that trans fatty acids are no longer available in Pakistan. There is another point I want to say. And Dr. Aisha gave a very good review. You see, now you can treat diabetes in many ways. And moreover, we have now drugs which can benefit, reduce renal and cardiac complication. So we are in an optimistic way, we can treat our diabetic much better. And of course, prevention is the best. We must, as Dr. Najmul Islam said, we should try to become we were 10 on the list, now we are 3 on the list. 1 and 2, they are genetically 50% diabetes. So we cannot do anything. We cannot become 1, but we can become 10. I again want to thank the organizer and our worthy speaker. They gave very good talks and good questions from the audience. And I hope that we'll be able to reduce diabetes in our country, prevent complication, so that we will say healthy living with diabetes. Thank you.
Thank you very much. So at the end, I would like to invite the chairs to hand over the souvenirs to our worthy speakers. Sir, सर बस इधर ही है सर So our first speaker, Dr. Saeed Meher Sahab. सर आ जाओ मैडम डॉक्टर आयशा शेखर आ जाइए जी